Hi, this is Morgan Knoll Shamblin. Um, my presentation is on implementing predictive analytics for the prevention of postpartum hemorrhages. This is for the DNP F&P program at Liberty and the class Nursing 718 Informatics Technology and Trends for Transforming Healthcare. So, introduction and problem statement: why implement predictive analytics? Today I'll be presenting an informatics-driven solution to a critical challenge in my present-day clinical environment, the prevention of postpartum hemorrhages. As a DNP prepared nurse, I am tasked with leading healthcare transformation through the integration of nursing science technology. The problem being addressed today is significant. Current data suggests that approximately 20 to 27% of all maternal deaths are associated with postpartum hemorrhage. This translates to approximately 70,000 to 140,000 deaths annually and affects about 5 to 10% of all deliveries, meaning it's a major cause of severe acute maternal morbidity. Postpartum hemorrhage is the primary cause of maternal death, with higher rates in the low and middle income countries. In some regions, it can account for over 40 to 50% of maternal deaths. Severe postpartum hemorrhage is defined as blood loss greater than or equal to 1,000 milliliters of blood, and it often leads to severe complications including shock, organ failure, specifically acute renal failure, adult respiratory distress syndrome or ARDS, disseminated intravascular coagulation or DIC, and if a hysterectomy is indicated, it can indicate or lead to a permanent loss of fertility. The primary cause of postpartum hemorrhage is due to uterine atony, which is responsible for nearly 70% of postpartum hemorrhage cases. While mortality from postpartum hemorrhage has decreased in high-income countries due to more efficient management, it remains to be a high occurrence in areas with limited resources. Despite best efforts, manual monitoring and incomplete documentation often result in information overload, in which critical patient data is buried in the EHR, or the electronic health record. This presentation focuses primarily on an informatics and technology project that is grounded in evidence-based practice. The end goal is not a simple digital fix, but rather a strategic integration of technology that improves clinical judgment and patient safety. Throughout the presentation, I will demonstrate how some of these specific informatics tools, like predictive analytics, can leverage both quantitative and qualitative data to bridge the gap between the high-volume data and actionable bedside knowledge, which directly aligns with the DNP essentials surrounding information technology and healthcare policies. Proposed technology solution. So the technology overview of predictive analytics. To address the gaps identified in the current nursing workflow, I'm proposing the implementation of EHR Integrated Predictive Analytics, or an AI Enhanced Predictive Analytics Dashboard. So this technology is not just a standalone solution, but instead it works as an integrated clinical decision support tool that is designed to reside within a pre-existing electronic health record. Unlike traditional retrospective reporting, this tool is able to use real-time data streaming and provide more accurate and specific situational awareness for clinical staff. The core functionality includes automated and updated risk scoring tools and color-coded priority alerts. Through the transformation of physiological data into a visually striking risk trajectory, the technology can assist the DNP-led team in moving from a reactive stance to a more proactive one. This aligns with the informatics principle of the Data Information Knowledge Wisdom, or the DIKW framework, and synthesizes disparate data and information into clinical knowledge that will enable wiser and faster bedside interventions. Evidence-based rationale. The synthesis of literature that I chose was CDSS integration into nursing care. So grounding informatics in evidence is what distinguishes a DNP-led project from a simple technological upgrade. For this project, the rationale is built upon a synthesis of up-to-date, peer-reviewed literature, which consistently demonstrates that technology-integrated patient care will optimize patient outcomes. The primary theme in recent evidence is that clinical decision support systems, or CDSS, significantly reduce the cognitive burden on nurses. By automating the analysis of complex data sets, nurses are more able to be present at the bedside and possess greater insights into personalized patient care rather than spending time manually calculating risk scores at the computer. This project utilizes the DIKW framework and briefly mentioned on the previous slide. In moving beyond simple data collection from the EHR to the knowledge stage, we can ensure the technology provides the context that's crucial for clinical wisdom to be applied. This evidence-based approach will ensure that the technology solution is functional while also being clinically meaningful and aligned with current standards of nursing science and practice. Quantitative data support. So this is just a chart that I got from one of the studies that I was looking at for this project by Susano et al. 2024. So basically it just compares the data from a group that had predictive analytics applied to theirs and a group that did not. So the yellow is the group that had the risk factors that were able to use the predictive analytics versus the ones that were not. So to move this proposal from a simple concept to reality, we must look at the numbers in the data that's presented. Quantitative data that supports interventions in nursing informatics is very compelling, and according to most recent industry benchmarks, facilities that have implemented this specific type of predictive technology have seen a positive correlation in the prediction of PPH with the use of a predictive analytics tool. One study that we mentioned that I took this chart from Susano, revealed that with the use of the naive Bayes, or the NB, and the support vector machine, the SVM, which are two predictive analytics EHR integrated tools, they're like machine learning tools, there's a 92.1% accuracy rate of prediction using these tools. So this study shows that the use of these machine learning algorithms can effectively increase the prediction of both intra and postpartum hemorrhages compared to traditional just upon admission risk assessment tools. This study considers personal risk factors for postpartum hemorrhage, and statistical significance of the percentage reduction was set at p is less than 0.05. A table from the study is provided. It shows the correlation between these values and the risk assessment conducted for PPH and how the statistical significance is evident when using these predictive analytic tools. Implementation strategy and workflow design, so steps for integration. I chose a pilot platform approach. So execution is where strategy really meets reality in these approaches. The implementation of these tools should follow a phased pilot platform approach. So it could be a solid pilot stage, which would last about 4 to 6 weeks, which allows for adequate time to learn to use the tools while also allowing for ample time to reap benefits from the adjustments. Super users or staff nurses who are tech savvy and like informatics and can help provide peer-to-peer support in real time should be, handpicked and identified to allow for a more seamlessly transition into the new tools at the bedside. For the workflow impact, to impact workflow, these tools must be viewed as a redesign of already existing workflow. The goal is not to add a new task to an already overflowing plate and to overburden nurses, but to redesign the workflow to decrease the burden on nurses. For instance, instead of a nurse having to manually check a score every 4 to 6 hours during their shift, the system will instead send an alert to the nurse and the provider only when a deviation from normal occurs, which would trigger a specific early warning protocol. The transition from periodic checking to exception-based monitoring and charting is a hallmark of increased reliability through alignment of the software's output with the nurse's natural movements, such as notifications appearing on central monitoring devices or showing alerts upon logging into the EHR. These tools can ensure that the technology is working as a resource for the nurse and that the nurse does not feel burdened by the change in technology. The technology should work for the nurse and not the other way around. Ethical, legal, and policy considerations, compliance. So we need to be compliant with HIPAA, high-tech, and data security protocols. As D&P leaders, we must glance beyond and consider the ethical and legal issues that may arise when using digital interventions in patient care settings. First and foremost, it's our commitment and duty to HIPAA and the High-Tech Act. This project should implement end-to-end encryption to ensure patient data remains protected and secure, whether it's being viewed on a mobile device, or on a central monitor. Beyond security, the ethical issue of algorithmic bias also must be addressed. This technology should ensure its predictive models are validated across diverse patient populations in order to prevent healthcare disparities and patient care deviations. From a policy standpoint, The implementation of new technologies warrants an update to the standard of practice for nursing documentation in healthcare organizations. Since there is a movement towards charting by exception, being supported by automated data, we must ensure that the policies that exist clearly define the responsibilities of the nurse and the clinical team when an alert is triggered. This will ensure that clinical judgment remains the final authority in patient care and protect the patient and the clinician through the creation of a clear and defensible framework for technology use in the patient care setting. Evaluation. So how are we going to measure the success of this? So success metrics like the SMART goals and patient safety indicators are helpful with this. The evaluation plan is founded on SMART goals, so specific, measurable, achievable, relevant, and time-bound goals. Approximately 6 months or so after the pilot and implementation, a formal outcome analysis should be conducted. So we'll look for quantitative data. So we're looking for approximately a 10% reduction in unplanned transfers to intensive care units and a decrease in the mean time to intervention in a postpartum hemorrhage. So the system bypass rates can also be tracked to see how often clinicians are getting alerts and are silencing or ignoring the alerts, which can be a critical measurement for detection of staff alert fatigue as well. Qualitatively, there are staff surveys that can measure technology acceptance scores, and sustainability is the ultimate goal here. So to ensure that this is not just a simple short-term solution, there should be a Nursing Informatics Council that meets throughout the year to review data trends and refine system capabilities and efficiencies. This will ensure that the technology can evolve with the needs of nurses and clinical staff. Discussion and lessons learned throughout creating this project. There are barriers to all projects. No nursing informatics tools are introduced without barriers. So throughout the development of this project, 2 primary challenges are identified: alert fatigue and interoperability. If a system triggers too many alerts that are deemed to be low priority, clinicians are going to eventually tune them out, which can lead to the jeopardization of patient safety. In order to prevent this from happening, IT should work closely with nursing and clinical staff in order to sensitize the algorithm that will lead to alerts only being truly clinically significant. Another potential issue is the importance of interprofessional collaboration and interoperability. So this isn't just a nursing project, rather it necessitates involvement from hospitals and the IT department to ensure that data can flow seamlessly among systems. These challenges can show us that informatics is central to the care of patients as people and not just about software and technology. As DNPs, we should maintain a crucial link between technical engineers and people developing informatic tools and the frontline clinicians who will use them. Conclusion and DNP practice input. In conclusion, this project proves that when informatics technology is grounded in evidence-based practice, it can be a powerful catalyst for optimal patient outcomes. We have seen how quantitative metrics support the safety of using these tools and how qualitative feedback shows the value of this tool in the nursing workflow. As DNPs, we maintain the position that technology should never replace personal patient care, but it should complement it and help it flourish. By integrating predictive analytics for the prevention of postpartum hemorrhages, we can fulfill our duty to the DNP essentials through the involvement of patient care and healthcare quality through information management. This isn't simply the adoption of a new technology, but it's a change in the culture of patient safety and how we're improving patient outcomes. Thank you for your time, and I look forward to hearing your feedback.